And good morning. Hello and welcome to the first session for today in relation to health and wellbeing. Firstly, I'd like to acknowledge the traditional custodians of the ACT people, the land of the Ngunnawal people, and pay my respects to both elders past, present and emerging. I'd also like to acknowledge the contribution they make to this city and surrounding region. And I'd also like to pay respects to all First Nations colleagues here in this virtual space today. Thank you and welcome. Look, I do hope that you all had a lovely evening last night. You were able to rest and restore, reflect on some of the learnings from yesterday, and are ready to go for a real jam-packed session this morning. I might just quickly introduce myself. My name is Sylvia Lappick, and I'm the ACT AYJC representative. I'm also the Executive Group Manager Deputy for Child Youth Protection Services in the ACT, and I'm really looking forward to today's session. Before we get started, I might just quickly go through some housekeeping for those of you that may not have attended any sessions yesterday. So if you have any questions throughout the session, please use the Q&A on the top right-hand corner. So you'll see, or the Q&A on the right side of your screen. And if you have any technical difficulties, please use the live support button at the top of your screen. To view this on a large screen, you can click the arrows in the top right hand of the video where I am now, and the screen will be larger. Now, in terms of the session, we do have 3 sessions today. So I will introduce each speaker, and at the end of the presentation, you will have an opportunity to ask questions through the Q&A. So throughout the session, if you have any questions that do come up, please pop them in the chat and we can have them ready to go when we have our Q&A space. If we run out of time and we don't get to all the questions, the presenters will take the opportunity to write down some feedback for you in relation to your question in the chat as well. All right, that takes all the housekeeping out of the way, and I really now like to warmly introduce our next presenter. So this session is in relation to health and welfare outcomes for young people following release from incarceration in Queensland, Australia. Our presenter is Associate Professor Rohan Borschmann, who is a psychologist and Deputy Head of Justice Health Unit at the University of Melbourne. His work focuses on the health of young people and adults who come in contact with the criminal justice system. I warmly welcome Rohan. Thank you.
Thank you very much. Thanks everyone for joining today. As you heard, I'm just going to be talking about a study that we conducted recently looking at the health and welfare outcomes of young people versus their older peers after release from incarceration in Queensland. Before we begin, I'd like to acknowledge the traditional custodians of all of the lands on which we meet today. For me here in Melbourne, it's the Wurundjeri people of the Kulin Nation. And I'd like to pay my respects to their elders past, present, and those emerging. And I'd also like to extend that respect to all First Nations people joining us today. By way of background, we know that people who come into contact with the criminal justice system, and young people in particular who experience incarceration, they're a very vulnerable group that typically come from life trajectories that are characterised by a whole range of adverse experiences, disadvantages, instability, intergenerational trauma, abuse and neglect. And perhaps not surprisingly, they also have increased rates of mental illness, cognitive disability, a whole range of substance use disorders, physical and health conditions compared with their general population peers who haven't come into contact with the justice system. And also when compared with their older peers who have experienced incarceration, younger people report higher rates of things like smoking and injecting drug use and alcohol misuse, both prior to and during incarceration. So that is to say that your average young person who experiences imprisonment, multimorbidity in this population is normative. So your average person is going to have multiple physical and mental health conditions compared to sort of their peers. Now, younger people who experience incarceration also report lower rates of, completing school or educational achievement and lower rates of employment prior to becoming incarcerated than their older peers who incarcerate. So despite this, we don't know a lot about the health and welfare outcomes of this vulnerable group after they're released from incarceration. So that's what we're looking to address with this study. Now, we know that the period when people are released from incarceration can be a really challenging time for a lot of people. And that's understandable. You know, they have to, they're trying to deal with finding a place to live, gaining access to health services, reintegrating into families and communities. And so quite often the release can compound that pre-existing disadvantage that they're already experiencing. But we don't know much about how this transitional period is experienced by adolescents and vulnerable adolescents who, if they were in the community and not in prison, would be recognised as having very age-specific support needs. And so they'd be receiving extra help if they weren't in prison. And we also don't know much about how young people experience this transition period compared to their older peers who are released from prison. And this kind of information would be really useful because it could help inform the development of prevention strategies and health promotion strategies that are age-specific, both before incarceration, during incarceration, and upon release. So with that in mind, the aim of our study was to try and examine whether the health and welfare outcomes of adolescents differed to those of the older adults, we call them adults in this presentation, during the first 6 months after release from prison in Queensland. So we used data from the Passport study, which is a fantastic prospective study led by Professor Stuart Kinner from the University of Melbourne. And it was a randomised trial of a case management intervention looking to get people in touch with services upon release from prison in Queensland, Australia. So we managed to recruit 1,325 people, around about 4/5 were male, recruited from 7 different Queensland prisons. And we interviewed them right before they were to be released. So everyone that was enrolled was expected to be released within about 6 weeks of coming into the study. Now, 1/4 of the people were aged under 25, and that's the cutoff for what we're calling adolescents in today's presentation. So 3/4 over 25. And the sample was representative of all people released from prison during the study period, with the exception of we intentionally oversampled women so that we could permit sex stratified analysis later on. So we interviewed everybody in prison just before they were released, and then via telephone follow-up at 1, 3, and 6 months post-release. And those interviews were all a really complex, comprehensive battery of physical and mental health and social welfare type questions. So on the screen here is just a selection of some of the things that we talked about, and I've just divided them into health-based outcomes and welfare-based outcomes for this presentation, and all of these were dichotomized. So for example, the unsafe sex was, have you had unsafe sex, unprotected sex with a partner in the past month, yes or no? Have you attended a GP in the past month, yes or no? So the participant activation here is when somebody has high activation, it's basically they're feeling like they're in control of their own health and their own health care. So if they have low activation, it's almost like they don't feel as though they're fully in control of that. We looked at psychological distress using the Kessler 10, the K10. We looked at alcohol use, tobacco use, and ATS is amphetamine type stimulant use as well. And in terms of welfare outcomes, in amongst others, we looked at unstable housing, whether the person felt they had social support, adequate social support, unemployment versus employed, and whether or not they were living in poverty. And for all of these outcomes, we compared the adolescents with adults. So what did we find? There's a bit to get through, and I've tried to basically give a snapshot of some of the domains in which there was a different experience by adolescents and adults. So you can see here after 1 month, adolescents were less likely to report high levels of psychological distress. So they felt feeling less distressed. But more adolescents reported having low activation levels. So that's a negative outcome, so to speak. And more adolescents also reported having used amphetamine type stimulants. And also adults were 3 times as likely as adolescents to have visited a GP. So after 1 month, the adolescents not visiting the GP and sort of engaging in more risky substance use than their adult peers. After 3 months, this had continued. So adolescents did report higher rates of problematic alcohol use. and still adults were more likely than the adolescents to have visited their GP once. So that similar trend after 3 months. After 6 months, adolescents were 3 times as likely to have used amphetamine-type stimulants compared to the adults. They were also more likely to report high-risk alcohol use. And as with the previous 2 assessment points, adults were more likely to have visited their GP since the previous assessment. Now, in terms of the welfare-based outcomes, after 1 month, adolescents were 3 times less likely to be unemployed. So that's a positive outcome. They were much more likely to be employed than their adults, and they were less likely to report low levels of support. So they're basically more likely to be employed, and they're more likely to feel supported after 1 month, which is obviously a good outcome for them. After 3 months, they were still far less likely to be unemployed, which is great for younger people. But then after 6 months, the differences had pretty much attenuated. So there weren't really any significant differences between adults and adolescents to speak of. And you can see here, this is just a bit of a visual representation. So on the y-axis there, we've got the adjusted odds ratios of experiencing a certain outcome, such as unemployment, when adults were the reference category. So this is how adolescents compared to adults. And so you can see along the bottom there, adolescents were much less likely to experience unemployment, less likely to feel unsupported socially, and less likely to feel distressed, all of which are great outcomes for the young people. But they were also more likely to have not visited a GP, so less likely to have visited a GP, and more likely to have used substances in the past 4 weeks, which obviously is not a great outcome in that regard. So some of the implications of our study, we thought that we really did see a different trajectory between adolescents and adults in relation to the health and welfare outcomes during the first 6 months after release from prison. And our findings do add to a growing body of literature looking at these outcomes. But as far as we can tell, we were one of the first studies to compare them with, compare the ages of adolescents and adults in terms of their outcomes. So we did find several differences between the 2 age groups on several health and welfare-based measures. And our findings do highlight the need for integrated, improved and age-specific support for adolescents during this really critical period, transitional period from prison to the community. And we thought specifically these would include strategies to discourage risky substance use, because they were recording far higher rates of amphetamine use and alcohol use. How to capitalise on their social support network. So it was fantastic that they were feeling more supported than their adult peers, but also trying to find a way to capitalise on that and having pro-social interactions. And also we thought we need to promote early primary care contact after release from incarceration, because as the results showed, the adolescents were less likely to report having visited their GP. And some subsequent work using this cohort by Dr. Jesse Young showed that if you do make contact with a GP within the first month of becoming released from prison, your health outcomes further down the line are typically better than if you haven't engaged the services of a GP. So it is really important to get young people and old people into touch with the GP once they're released from prison as soon as possible. Our study did have a lot of strength and a few limitations. So by having a lot of follow-ups within a short period, we were able to find a bit more of a nuanced picture for the health and welfare outcomes over time. And you could see that they did change over time, particularly the welfare outcomes. Our sample was quite large, 1,325 people, and it was representative of all people being released from prison in Queensland at the time. So that did help with improving the generalisability of our findings. It's one of the largest prospective studies of people released from prison globally, and one of the first to compare health and welfare outcomes between the ages. A couple of quick limitations before I run out of time. Everything was measured by a self-report, so there's potential for poor recall or perhaps people saying what they think the so-called right answer might be, social desirability bias. And also, to the extent that any outcomes were associated with loss to follow-up, the study may have experienced bias attrition. So those who were lost to follow-up might have been more likely to experience the negative outcomes. And also, while our findings can be reasonably generalised to Australian jurisdictions, we would need to replicate them in other countries to see whether or not it translates into different settings. This is the paper that we had published just this year in the journal Adolescence. And finally, given the large and growing number of vulnerable adolescents who experience incarceration and the evidence of their poor health outcomes, there really is a need to invest in evidence-based efforts to improve their health and welfare outcomes. And that has the potential to break cycles of reincarceration and hopefully contribute to reducing health inequalities and inequities at the population level. So before I finish, I'd just like to thank Professor Stuart Kinner and Dr. Dominique D'Andrade, my colleagues on this study. And I'm very happy to try and answer any questions that you might have now. And if you want to get in touch via email, please feel free.
Wonderful. Thank you, Associate Professor Rohan. That was a really insightful study. Interesting around, it is quite worrying when we think about our young people not accessing primary healthcare, and we're thinking about that opportunity area there. And I think that's what you're really looking at here, is what's our opportunity to improve the connections for young people when they do exit the system. So it is quite worrying data, particularly around unemployment. Unemployment is great data, but we really want to understand a little bit more about drug use and GP access. So thank you so much, really insightful. I do have a couple of questions in the chat, so we might go to those. Sian Ostermeyer has asked, has really acknowledged the work here and some interesting findings, and wondering whether adolescents were on parole. I'm wondering whether adolescents were on parole, and or whether you looked at those on parole versus those who are not. Good question.
Thank you, Sonna. Great to hear from you. Sonna's a colleague of mine at the University of Melbourne. Sonna, we didn't look at whether or not they were on parole, although we do have those data, so we'll be able to follow that up, I believe. Unfortunately, I can't give you a very good answer today, sorry, but I can certainly get in touch with you after this to try and find that out. Because you would assume that with a higher level of contact with services even after release, hopefully that could lead to some better outcomes, but that would be speculating.
Because it certainly is a very large sample size, isn't it, Rohan?
Yeah, it's a really fantastic
I
study.
think that's what was impressive, that you were able to capture such a large sample size.
Yeah, and what I didn't present on today was that an even bigger part of the study was this amazing linked data set that Professor Kinner was able to put together, where we actually linked about 10 different state and national data sets, emergency department, hospital, the National Death Index, all these types of things, going back in time before incarceration and forward in time after incarceration. So there's this huge wealth of really rich data, both from the questionnaires, but then much bigger, broader data where there's zero attrition because we use linked data. And so it's a huge study, and full credit to Stuart Kinner for putting it together. But yeah, we could do many more presentations where the linked data were used, because this was just the questionnaire data that I was talking about.
Yeah, I think there'd be a lot of interest in seeing some of those, I guess, how that information is then extrapolated into different findings. It'd be really interesting to see that linked data set.
Just
I know
quickly,
yesterday,
if you looked at the Justice Health Unit website from the University of Melbourne, there's a whole load of publications that we've managed to produce using these data. So, and get in touch. We'd love to talk more about any of them if you'd like.
We certainly can't underestimate the complexity of linked data sets, about data sharing deeds and how that's all done. I think it sounds great at the end product, but it's really hard slog to get there. So a really big acknowledgement around that. I know yesterday there was a presentation from our New Zealand colleagues on a data modelling and linked data set as well. And I think some of those challenges in trying to get that together. So it's great to hear that Queensland have done something very similar in that sense, about looking at life outcomes and tracking them through the course of life events, which is fantastic. Look, I have got some other comments here around the study. Is really quite interesting from Mary, and really clear presentation. And I just wanted to end this by saying thank you so much for sharing those results. If anyone else has any other questions, please feel free to pop them into the chat, and Rohan will be happy to answer those out of this session. So thank you so much, Rohan, and I hope you have a good conference day.
I feel, thank you, you too.
Thank you. All right, that's wonderful. So look, we'll now move into our next presentation. This session is titled Utilising Intensive Wraparound Service to Work Differently with Tamariki at Risk of Future Offending Behaviour. And so we're really pleased to have, I'm just going to pop up a couple of notes on my screen. 1 second. All righty. I have to say our technology is doing really well, but I don't want to jinx it. Now, let me present to you 2 presenters. Our first presenter is Emily. Let me just get my notes. Emily Lodge. And Emily Lodge is the practice leader of Arangi Tamariki and has been working in the care and protection and youth justice space for approximately 20 years. And also her colleague, Aaron Matchitt, who's the social worker at Arangi Tamariki. He's been working in the care and protection space for the past 4 years and has been working in the Mana Tamariki team for the past 3 years. I warmly welcome Emily and Aaron to the stage. Thank you.
Tēnā koe, Sylvia.
Thank you.
Thank you everyone for joining us today. I'm just going to open with a mihi. Toia ki te rangi, toia ki te whenua, toia ki te moana, tihei mauri ora. Ko te mihi tuatahi ki te ārua, nā nane ngā mea katoa i hanga. Ko te mihi tuarua ki a papatu nuku rawa ko rangi nui, tēnā korua, tēnā korua, tēnā korua. Ki te hunga mate, haere, haere, haere atura. Ki ngā kanohi ora, tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko eki mai nei ki tēnei kōrero i tēnei ata, ki te tautoko i ngā whakaaro o tēnei kaupapa. O tira, ka nui te mihi mo tō koutou manua nui, ki te hui tahi mai, ki te tautoko i ngā kaupapa o tēnei wānanga, tēnā tātou katoa. Ko waiau, ko tēnei taku pepea poto ki te taha o tōku pāpa, ko tarawera ko maungarangi oku maunga, ko tarawera ko otara oku awa, ko te arawa tōku waka, ko te arawa ko te whakatōhia oku iwi, ko Ngāti Rangitihi, ko Ngāti Ngāhere oku hapu, ko Ngāti Rangitihi, ko Rangitihi ko Terere oku marae, ko Matchitt tōku whānau, ko Aaron Matchitt tōku ingoa. Nō reira, tēnā koutou, tēnā koutou, tēnā tātou katoa. So kia ora everyone, and thank you for joining us this morning. My name's Aaron Matchitt. I'm a social worker with the Mana Tamariki team, part of the Tamaki Makaurau specialist teams with Oranga Tamariki. I've been working with the team since its inception as a pilot 3 years ago, and have been working in the care and protection space for the past 4 years. And I'm just going to hand over to my colleague, Emily, to introduce herself.
Nā mihi Aaron, tēnā koutou katoa. Ko ai I whānau mai o ki Tamaki Makaurau I tupu e hi o ki Tamaki Makaurau ki Bayswater ahau e noho ano, ki Oranga Tamariki ahau e mahi ana. Ko Emily Lodge toku ingoa, tēnā koutou katoa. Kia ora everyone, my name is Emily Lodge. I was born and grew up here in Auckland, as did many of my ancestors stretching back 6 generations. I work for Oranga Tamariki as a practice leader in the Tamaki Makaurau specialist teams. I was the first supervisor for Mana Tamariki when it started 3 years ago, starting originally as a pilot with Oranga Tamariki with the support from external influencers, such as Dr. Ian Lamley and philanthropic funding from Vodafone and the Tyndall Foundations. And in the last few years, it has become an official part of the Oranga Tamariki structure within the Auckland region. Mana Tamariki has been a highlight of my career, and I'm excited that Aaron and I can share a snapshot of the framework we use, highlighted through the success of one of the whānau families that we worked with. Mana Tamariki uses the intensive wraparound framework. Wraparound originated as a philosophy that was seen throughout social service practice in North America. There are similarities with the philosophy and practices that have been developed here in New Zealand, Aotearoa, such as family group conferences. Since the early 2000s in North America, the wraparound philosophy has been developed further and created into a framework of practice, which has been utilised across different social service spaces. Throughout this time, there have also been multiple studies completed that evidence the benefits of this way of working, creating sustainable change within whānau families facing challenges with their tamariki or children. Mana Tamariki isn't the only group using the wraparound model in New Zealand, Aotearoa. It is also widely used by the Ministry of Education and Health, particularly in the youth mental health area. The Mana Tamariki approach is about recognising that wraparound intervention is part of the whole whānau journey. Social workers use the engagement process to have a deeper understanding of the whānau's cultural identity, and with this ensure cultural support to tailor the appropriate engagement. Currently, Mana Tamariki has a close relationship with Mana Whenua ki Ngāti Whātua ki Ōrākei, whereby kaumātua or elders support and guide practice to working with whānau and responding to their cultural needs. We utilise this picture with whānau to help explain our process with Wraparound. The process of Wraparound is a journey. The team will build and ride in the waka guided by the underlying needs or stars, supported by the whānau family and strengths, and hopefully work towards their goals. Wraparound has 10 principles. These principles align well with the Oranga Tamariki values. The Mana Tamariki program is voluntary for those whānau already involved in an intervention with Oranga Tamariki. For instance, those whānaus that may have a family group conference plan or be involved with the family court. Referrals require a tamariki or child within the whānau to be aged between 6 and 10.5 years at the time of referral, with some markers that could indicate poor life outcomes. For example, disengagement or challenges at school, behavioural issues at home or in the community, adults or older siblings who have offended or are currently offending. The social workers are guided by the principles throughout their engagement, supporting whānau to have a voice and having the team understand what is important to the whānau has helped whānau that Mana Tamariki have worked with feel more connected to the plans they make and driven to achieve their goals. Whānau often feel empowered when their strengths are highlighted and there is recognition that things have and can go well for them. The process of Wraparound can be utilised in a holistic way, which supports not just the tamariki, but also the whānau to better outcomes for themselves and their well-being. Aaron is going to share a case example highlighting a whānau that, where the identified child had challenges related to his neurodiversity. Thanks, Aaron.
Tēnā koe, Emily. So firstly, I would like to acknowledge the social workers that worked alongside this whānau through some really challenging moments before we got involved. They played a really vital role in clearing the pathway for future success. Most importantly, though, I want to acknowledge this whānau for allowing me to share their story and achievements at this conference. Proud of how they've come and they didn't hesitate to sing. I'd hope to do their journey, honour their journey, but I think 15 to 20 minutes may not do justice to their story, but I'll try my best. So their journey with Mana Tamariki illustrates the use of intensive wraparound as a model for care planning. But more importantly, it highlights the strengths and resilience of this whānau in overcoming some significant challenges and supporting this child to get to where he is today. So it brings me a lot of joy to speak to you about this today because I think of him now as a child who is happy, confident and connected, living with his father, thriving at school, excelling at sport, surrounded by loving family and a supportive community. It is humbling to see where he is today because things look really different for him a few years ago. This child has a complex history that was characterized by a chaotic start to life. And today I'll share the part of the journey that we were privileged to be a part of. So just a bit of context. Mana Tamariki received this referral 3 years ago when he was about 8 years old. He'd come into the care of Oranga Tamariki following reports of physical and emotional abuse and some significantly challenging behaviours that were unable to be managed by his whānau. He'd spent time moving around in the care system before being placed with his paternal auntie and grandparents. His behaviour was indicative of a child with high and complex needs resulting from a combination of FASD, ADHD, and his experiences of trauma. So he was hypervigilant, he was at times withdrawn, struggled to interact with others, build relationships, would often lash out physically and verbally when he felt overwhelmed. So unsurprisingly, this meant that his early schooling experiences were really disruptive and characterized by difficulties with learning, relationships, suspensions, exclusions, and changes in school. Everyone around him struggled to manage his behavior and keep himself and others safe. So that's a bit of a snapshot of where things were when Mana Tamariki took this referral. And so now I'm going to take you through their journey through all the phases of Wraparound. So the first phase is engagement and team preparation. And the goal of this phase of Wraparound is to build a groundwork for trust and a shared vision within the team. So this involves orienting the family and the team members towards the kaupapa, or purpose and objectives of Wraparound, ensuring the family's voice and choices are at the centre, and establishing the needs and strengths of the family and child as a foundation for an individualised plan. So a really key part of this was getting to understand the family story, and information from the whānau members that creates a picture of this child's early environment, the risk factors, the strengths and successes. The family story helps the Wraparound team understand the reason for his behaviours, but it also draws out the coping strategies that help them get through the really hard times. So we spent a number of weeks with the child, parents, aunties, grandparents, and even a great-grandparent to develop a deeper understanding of their story. Their shared perspective was multi-layered and gave meaning to their current situation. So mum and dad would speak about their challenges early on, being young and unprepared for parenthood in a dysfunctional and volatile relationship. They talked about their own struggles with past trauma, how their own needs were unmet, and their struggles with challenges that life threw at them, and how that impacted it. They talked about more difficult to manage as he became older. He would quickly escalate into full-blown violence with little warning. They spoke about their desperation at the lack of supports, his struggles with school, the pain of feeling that they couldn't manage him, and the grief of him coming into care. In these early stages of his development, they had no idea that he had ADHD, or an intellectual disability, nor did they fully grasp the impacts of his early life on his worldview. In hearing this kōrero, or the story, we tried to support a shift from blame to understanding, to reframe his behaviour as a way of communicating that things weren't okay for him, rather than intentional acts of violence. So despite these significant challenges, they persevered with the limited resources they had. They loved him and they wanted him to succeed and be happy. The family story also gave us a deeper understanding of their values and culture as a Samoan and Māori whānau. A key value was the multi-generational relationships that were intrinsically linked to his sense of identity, belonging, and safety. There was a shared sense of kaitiakitanga, or guardianship, for him. Uncles, aunties, parents, and grandparents were all responsible for his care and well-being. This collective responsibility was one of the many strengths that we're able to elicit through that whānau story. And identifying strengths is a really pivotal component of Wraparound. So it's these strengths that we draw upon to develop the plan. And they're not simply things that people are good at. They have a functional element to them that can be transferred across different settings and different situations. So bringing out these strengths helped the whānau see what a better life could look like for them and their child. They created a family vision and let the team know what they were striving for, and guided the Wraparound process. They were then able to select a team of supports, natural and formal supports from different systems that were influential in this boy's life. So for example, we had school staff, whānau members, Ministry of Education psychologists, therapists, social workers. And then we began exploring what his needs were in order for the family to achieve the goals in reducing that challenging behaviour and realising their vision. So Wraparound plans are guided by meeting needs. So if you can sort of see in the top right-hand side of the screen, there's a little image of a waka about to embark on a journey. The underlying needs of this journey. So if we're not heading towards the right stars or not meeting the correct needs. So typically we look at needs as something that's strongly desired, an obligation, or necessary steps towards a goal. But in Wraparound, we're more concerned with the set of conditions that cause a behavioural situation to occur or not occur. So exploring needs helped the team to understand the function of this challenging behaviour rather than just seeing it as problematic. So I'm just conscious of time. So I'll just take us through phase, which is plan development. So the second phase of plan development, and this involved getting all that preparation work done in phase one, and bringing the team together for a meeting or a couple of meetings to establish the plan. So the goals and visions were at the forefront of our minds, and we created a mission statement which established our commitment to support the family to achieve their goals. So we also created a a crisis plan to stabilise any issues that might flare up on our journey. I'll just quickly forward to phase 3. So phase 3 is plan implementation, and this is the ongoing process of reviewing and updating the wraparound plan while maintaining team cohesiveness and trust. So for this whānau, the phase took place over approximately 2 years, and we had regular meetings every 4 to 6 weeks. So at these meetings, we would review progress, onboard new team members, come up with new strategies that link to the strengths of the team, and over time developed a deeper understanding of the needs and kept moving the whānau towards their vision. So many of the strategies that came about sought to reshape the environment by reducing stresses, teaching him and the family new skills, and help him create and build trusting relationships. So for example, we did FASD and parenting workshops with the family, built his skills around emotional regulation, doing one-on-one work, sensory therapy, equine therapy, supported the school to better understand his emotional, social, and cognitive needs, help him feel safe, creating stable and consistent routines at home and at school, using visual planners, things like this that work to his strengths and the strengths of the team members. So these strategies built on top of each other, and we gradually began to see more pro-social behaviour. The more things went well, the more positive reinforcement he got from peers, teachers, and family. And over time, the family's perspective shifted about this boy. They felt more confident to support him. They were less reliant on the support of professionals and were able to manage things on their own. So the family became more invested in the process, and what was really key is that the boy's paternal auntie became like a po or an advocate for the family and represented them. And she was able to coordinate all their responses whenever there was a crisis or anything went wrong. So for example, he was living with his grandparents, but it became apparent that that situation was unsustainable and his grandparents couldn't care for him anymore. So she got the family around the table and made a decision that he needed to move back with his father. And we were able to sort of back this in the family court. And it was a really, really positive outcome for him. And he's done really well since he's been there. So this takes us to the last phase, transition. So by this stage, the whānau had achieved their goals and reached their vision. They were making really good, safe choices on their own. And this boy was thriving at home, at school, and in the community. They were in a position, with the support of their community networks, to maintain the positive changes that they had made. So not only were the whānau ready for a transition out of wraparound, but we, as Oranga Tamariki, were ready to and able to discharge the custody order out of family court and then discharge from Oranga Tamariki altogether. So I just wanted to acknowledge the fact that their success was built on the strengths that they already had, and they had them from within. So I wanted to use a proverb or a whakatauki that sort of captures that. So e fofo le alamea. So the alamea is a starfish that carries the antidote to its poison in its body. The proverb reflects the Samoan belief in the strength and capacity of families to find their own solutions to challenges, especially in relation to children and when those challenges come from within. Nō reira, kia kaha, kia maia, kia manawa nui, and thank you all for listening to this pūrako. Tēnā tātou katoa.
Wonderful. Thank you so much, Aaron and Emily, for sharing what is a true family-led decision-making approach at its heart of it. That wraparound model that you've sort of articulated, I think for some people, they might think they do this already, but what you've been able to do is really articulate clearly the different work that needs to happen in the different phases, and the investment of engagement in that first phase is so invaluable as you move forward for a better outcome. So thank you so much for sharing the wraparound model. And really the other takeaway for me, it is a journey. It is not about just connecting services and going, here you go. It's a journey. And I think you've been able to share, and particularly the case study helps us then translate what that looks like in practice. So thank you. Great presentation. We probably only have time for one question. So let me see if I can pull up Sarah's question. Sarah Butterfield, kia ora. And what was the upper age limit of the Mana Tamariki, 10.5? And if so, would OT consider raising the requirements of the program to 14? I think a really good question. Many kids aged 10 to 14 who are offending would benefit from this intensive wraparound service. What are your thoughts?
I can answer that. That's been an ongoing debate for us. I think within the development of the pilot, we were looking at trying to sort of locate tamariki or children in an earlier age, ones that were perhaps in primary school or just starting in what in New Zealand is intermediate or middle school, and wanting to work with them, successfully transitioning them through into high school. And so starting at sort of an upper age limit of 10.5 gave us that space to be able to work in that space before any of those behaviours became entrenched. However, again, it is something that is kind of on the radar and continually discussed, I guess, around whether we need a program similar for those what we call child offenders under the 14-year-old age group.
Look, thank you. If there are any other questions, please feel free to pop them in the chat. Emily and Aaron will respond to those. I'd like to close this session by thanking both presenters, and we really look forward to how the future results of this wraparound model are applied in different settings and across jurisdictions. So thank you so much. All right, so I might move us on to our last session, and I will introduce this session, and I am going to just quickly get my notes up so that I'm very organized. You can see I am a rookie at this. Let me see. All right, so our last session, responsive case management, knife crime program pilot. Look, we are really pleased to welcome Dr. Gemma Russell and Sally Norton to this presentation. Dr. Gemma Russell is the Director of Clinical Oversight and Rehabilitation for the Youth Justice Division within the Youth Justice System in Victoria. Now, Gemma brings with her expertise as a registered clinical psychologist to apply evidence-based practice approaches for working with young people in contact with the justice system. And this includes oversighting high-risk or priority cases and ensuring responsive case management and clinical service provision. We also welcome Sally. Sally Norton is a social worker and has worked in the Victorian Youth Justice System for 19 years, working in various areas: community youth justice, case management, court advice, team leader and management roles. She also held the role of Secretary for the Youth Parole Board in Victoria and is currently in a Senior Project Officer role in the Clinical Oversight and Rehabilitation Unit in Youth Justice. We welcome Sally and Gemma to the stage. Thank you.
Thank you for having us here today. We are privileged to talk about an innovative, responsive approach we are currently piloting in metropolitan Melbourne called the Knife Crime Program. We will take you through aspects behind the program to give you context about why we developed it, what it is about, the evidence which sits around knife crime as an offending pattern of behaviour, the co-design process, and now that we are at the implementation phase, key aspects of program implementation. One of the trends we observed in Melbourne, which led to the development of the program, was the higher incidence of violent crime involving weapons, particularly knives, which tended to be in the context of conflict between groups of young people or individual peers. These were geographically driven groups, and the conflict between these groups were related to where they lived. When we looked at the cohort of young people involved in or present at the time of their conflicts, these young people were either currently involved with youth justice for adjudicated matters or were just coming into contact with youth justice and sitting at the pre-adjudicated stage. We also noticed that social media had a large role to play in the organisation of peer conflict, whether that be through the facilitation of organised fights, meeting at particular locations, as well as the influence of peers through the use of social media. Once we realised that we had to pivot in our response to knife crime, we needed to set out an objective about what we were trying to achieve in designing a case management response. We needed to enable youth justice case managers, non-clinical staff, to be able to work directly with young people who they identified as being at risk of knife crime behaviours. And we wanted to provide them with a flexible and easy to use intervention with these young people. Using this intervention, case managers could achieve 4 key objectives: to reduce the incidence of violent offending with a focus on knife crime, reduce the impact of systemic drivers that contribute to a young person's risk of engaging in high-risk situations and knife crime, targeting the individual drivers that contribute to a young person's risk of engaging in high-risk situations and knife crime, and fostering a pro-social identity which builds skills and resilience. As we were working with a cohort of young people that were sitting across different levels of statutory involvement, we had to be clear in defining the behaviour specifically targeted by the intervention. We had to start with developing a definition of such behaviour for youth justice case managers to target. We defined knife crime as current or previous carrying of knives or similar type weapons, including makeshift weapons. The focus on behaviour rather than charges for violence or possession of a weapon. And you can see from this slide, we have an activity from the program that helps young people to understand the Victorian law regarding carrying of weapons and to also understand the different classifications of weapons in Victorian law. In reviewing the literature around knife crime interventions, particularly the information from the UK around knife crime, we saw that a lot of research speaks to push-pull factors involved in knife crime. This is important for us to think about. The push-pull factors had to be considered in relation to the design of the intervention, looking at the push factors that would push a young person towards potentially engaging in knife crime behaviours, the pull factors that would pull a young person towards potentially engaging in knife crime behaviours. We tend to see the push factors through the family and community system and pull factors through antisocial peers. And you can see on the screen we've listed examples for some systemic factors which sit under push-pull. We needed to think about how to intervene upon or disrupt these factors to make traction in reducing the influence on the push and pull drivers in order to influence behaviour change. In a moment, we'll speak about the involvement of the family and community systems, the push-pull critical in understanding the role of systemic drivers. The other aspect of literature we needed to consider was the role of R&R and how the central 8 criminogenic needs identified under this model interfaced as systemic and individual drivers of knife crime behaviour. So for those of you unfamiliar with R&R, we have some examples of considerations we needed to look into. You can see here on the screen where family is a criminogenic need and also a systemic driver. You can then start to understand the influence of family as a systemic driver on behaviour. For example, ineffective boundary setting and low monitoring by parents increases the risk of a young person engaging in high-risk behaviours. And this is the same with antisocial peers. Remembering that peers is a pull factor, so understanding the role of antisocial peers as driving high-risk behaviour. You can see through the example where the young person has felt loyalty to the antisocial peer group. This is when they are more likely to engage in high-risk behaviours with the antisocial peer group. One other aspect we needed to consider was individual drivers driving behaviour. Common ones that we know underpin knife crime behaviours are fears for safety, beliefs about knife carrying. It's common for a young person to think that if they carry a knife, it makes them safer. We could see this as a common cognitive distortion regarding safety. Other drivers contribute to this, such as looking cool and the connection to identity, status, and peer group belonging. You can see the dotted line on the screen here as well. This shows that we understand individual drivers can, in time, if the behaviour escalates, lead to pro-criminal attitudes. When pro-criminal attitudes become entrenched, we see entrenched antisocial attitudes more closely related to offending behaviours. As part of this work, we are trying to disrupt systemic and individual drivers so offending behaviour does not become entrenched. So we've just gone through the evidence base which informed our design, but the critical components required in order to design an effective intervention involved utilising a co-design approach. and engaging with key stakeholders such as cultural specialists, community, to understand exactly what they needed and to tap into their knowledge and expertise around the cohort and offending patterns observed in particular geographical regions across Melbourne. We started in one particular metropolitan region in Melbourne, which had a high rate of knife crime incidences, and we engaged in co-design work, utilising information from co-design consultations. This featured the specific cohort group, targeting and phasing of the program. One other thing we had to consider was the overrepresentation of particular groups. There were some cohorts where we needed to engage specifically with communities in order to understand the particular cohorts. There was overrepresentation of some minority groups in certain areas, and in some areas we could see some cultural groups living in family units based geographically. This related to migration patterns, and it was critical to understand their specific needs in order to respond to responsivity. This co-design process led to identifying the cohorts that would receive the program. Cohorts would need to be at a medium to very high risk of reoffending on the YLS or LS, and who were identified as being at risk of knife crime behaviours. We did this to ensure we were working in accordance with R&R principles. Phasing allowed us to consider young people with adjudicated matters, a smaller part of the YJ population, and also accommodate those with unadjudicated matters, which is a larger group within the YJ population. The majority of unsentenced young people had previous contact with youth justice before, so we were aware of their risk of reoffending, and this allowed us to consider the psychosocial phase. The psychosocial phase doesn't tap into any kind of offence pathway. However, it does prepare this group of young people by looking at some of those aspects which drive knife crime behaviour. The offence-specific phase targets offending, specifically the cognitive and behavioural elements of the offending pathways. This phasing allowed us the flexibility to deliver the entire knife crime program to sentenced young people and to also deliver the psychosocial phase to unsentenced young people. We knew that over time, unsentenced young people would have their matters adjudicated. So we started this group with the psychosocial phase so that by the time they got their matters adjudicated, they would be ready to start the offence-specific phase of the program. This gave more intervention opportunities early within the period of contact and also provided readiness work. So when the young people were sentenced, they could move straight into phase. Now, as you can see on this screen, we have some examples of activities from each phase. In the psychosocial phase activity, young people were asked to watch a YouTube clip about peers that meet in a park for a prearranged fight between two groups. This activity focused on developing victim empathy, considering the impact of knife crime behaviour on family, friends, and the community. And if we look at the offence-specific activity below, this focuses on helping young people identify some of those thoughts which legitimise and normalise knife-carrying behaviours and helping them start to make sense about what those thoughts mean. Youth justice case managers have traditionally adopted child-centric interventions to work directly with the young person. Although what we know is that multi-systemic interventions that work with the young person and their family, school, peers and community are far more effective. This was reinforced through the co-design process, where stakeholders identified it was critical to consider the very system the young person is involved in as part of the intervention. This meant we needed to design the intervention so the case manager worked with both the young person and the family when applying interventions. This approach benefits the young person, family and community by the sustained and generalised behaviour changes associated by working with family, addressing responsivity needs more holistically, and uncovering and intervening in the systemic drivers of behaviour, building on strengths of the young people and their family to promote wellbeing and healthy relationships. We found that we needed to map and think about the multi-systemic approach as part of identifying knife crime behaviours by identifying the systemic drivers contributing earlier in the offence chain, as you can see on the screen. Low parental monitoring contributed to absconding from home late at night, and if we look at the offence chain further, we can see how that will develop. Now we've worked through the co-design method that led us to the implementation phase. In order to stage the implementation across multiple YJ regions in Victoria, we started with one large metropolitan region and utilised dedicated training sessions at a local level. We used virtual training due to COVID-19 and followed up with local area practice sessions to reinforce concepts. We also include supervision support for case managers on the ground and for leadership teams, and delivered a dedicated reflective practice session discussing what worked, what didn't, and how to improve. We're still in the early stages of implementation. The first 2 pieces of training for delivery of the program and for supervision has been rolled out sequentially in metropolitan regions. Feedback was primarily case managers using different skill sets to work with young people and family, as this was new to them. Next steps include outcomes evaluation of the knife crime program, which will inform future revisions or changes to the program and determine the effect the program has on reoffending behaviour. Thank you.
Thank you, Sally, and thank you, Gemma, for your presentation. It sounds like despite COVID, things still kept going on and the work continued. You know, we hear about so many challenges and so many different things that COVID has impacted, but it sounds like it's been business as usual with even virtual training and a commitment to that implementation, which is so promising. So thank you for sharing today. I will go through some questions that we have received. So much interest in this particular session. If we could start perhaps with, we have, thank you for a very interesting discussion. I wonder if either of you could speak on any female young offenders you came across in this pilot, and if you observed any differences in female knife violence and intervention to males.
Sure, so I'll take the question, Sylvia, for today, because Sally's done the hard lifting for me through this presentation so far. So if we're talking about young women and girls that are involved with our youth justice system, they're a very small cohort, and what we know is they have quite distinct pathways that lead them into youth justice. So this particular knife crime pilot didn't exclude girls and young women, but we really encouraged our case managers to apply the concepts of the program as was relevant for the particular individual girl or young woman, because we knew the distinctions. As Sally sort of referenced, we're really in that early intervention phase, so we're not quite sure how many young people, young girls and women have been through the program as yet, but we look forward to evaluating, particularly around girls and young women, because this is an area we don't know a lot about when it comes to knife crime and the emerging trends around this group. So I think it's an exciting area to learn more about.
Yeah, I absolutely agree, Gemma. I think what we're seeing here in the chat is some really positive comments about the presentation, and whether there's also been a comment here from Craig Clark, who also wanted to thank you for your awesome presentation, good language there, and really like the focus on the early intervention work with a prevention focus. So I guess a great comment that looks at, you know, we talk about prevention and early intervention, but this is actually the doing, and the way that you've been able to use the co-design methodology, I think, is really looking at from a systemic level how we can start doing early intervention rather than just talking about it. So it's just a great application here. And also quite a few comments coming through about the multi-systemic approach, and really impressive around that. And for Ian Lambie, he also commented, Kia ora, Gemma and Sally, thanks so much for the very interesting presentation and for the mahi. Great to see you on the world stage, Gemma. Wonderful. And look, I think I might bring this to an end for our session. If anyone has any further questions for Gemma or Sally, please feel free to pop them in the discussion forum or in the live Q&A, and they'll be more than happy to answer those questions. But just wanted to formally thank Gemma and Sally for their time today. Great presentation. And I think a great presentation from all 3 sessions today. Thank you for listening, and I hope you have a fantastic rest of the day during the conference. Thank you all.